Good morning. Next is a plenary lecture by Dr. Jawaharlal Senaratne, who is a general and vascular surgeon in the UK. And he's going to speak to us on post-thrombotic events following the COVID infection.
Well, Jawaharlal, welcome. He's a graduate, an distinguished graduate of the University of Colombo. Did his postgraduate training here, and good that we inspired you into vascular surgery. He went off to the UK and then he's done well. Thank you for coming, and may I request you to give your talk on thrombosis during the COVID period, thrombotic events. Thank you.
Thank you for that kind introduction, ladies and gentlemen. So this I would call is adding vascular injury to the adding vascular insult to the COVID lung injury. What I'm going to do is to give you a brief understanding of what this COVID thrombosis is all about, and I would concentrate mostly on our experience in East Kent and our recommendations. I'm not going to dwell a long time on molecular biology explanations. This is meant to be a clinical guidance rather than a lesson in molecular biology. The idea is to benefit from our lived experience of managing this crisis, providing effective interventions during a period of a pandemic. So, in the early period, although as surgeons we do use PPE, this was unprecedented. We were not used to wearing face shields, although we do use some protection, and suddenly body suits and all sorts of PPE. And then there was a period when PPE was in short supply. So we didn't know what we could use, but we learned quite early in the course that the exposure period matters. If you have very short exposures, quite often you get away with it. So it was quite important to shorten the duration of operations as much as possible. Keep things simple. Keep things simple and get effective results. So that was the focus of doing things. It was a scary time because we didn't know how much of personal risk we were taking. It was unquantifiable. So, the current understanding, it is essentially an immunothrombosis. It's not unique to COVID. Any serious septic situation, viral infections could lead to immunothrombosis. Guidelines-wise, guidelines differed between countries. What was recommended in China was not what was recommended in the US, and the UK was far behind. So, there were various guidelines issued. I have put the Thoracic Society guideline in 2021, but in the early period of the pandemic, there was no real guidance. There were some guidance published by various institutions, but they were like very vague. So it was very difficult to decide what to do. Young people were affected. Lot of thrombotic problems were coming. We certainly noticed that there were lot more thrombotic complications presenting to us. And the results were poor. Even if you offered standard operations where we expect a certain outcome, that outcome was not happening. The outcomes were much worse in COVID patients who were COVID positive and came with these thrombotic complications. And results were emerging. People were having rapid publications saying, look, the overall message was, don't do your standard operations, the results are poor. We changed the criteria for certain operations. For example, standard teaching is to operate on an aneurysm when it's 5.5 centimeters. During this period of COVID, we didn't operate till there was 7 centimeters. We said the risk of operating on you before it was 7 centimeters was worse because we do open aortic aneurysm or even EVA and put them in HDU, ITU next to a COVID patient and they wouldn't come out. So criteria were changed, so we didn't operate till the aneurysm was 7.5 centimeters. And quite often we were faced with situations where young people with COVID came with a embolus, and they didn't go out, they didn't expect to go with an amputation, and that happened. That really happened. So we had to give explanations to people, and when consenting people, we had to think about what to say. Sometimes it was very difficult because it was difficult to explain to people what was happening. So one of the standard explanations I used to tell people is that older people, yes, we know that they will have more complications. People who have comorbidities will have complications. That's like, but younger people also can have very, very serious complications and lose limbs and even life. And one of the explanations I used to say is that if you are faced with a car crash in the motorway, if you are in an old Ford Prefect with very little protection, the chance of your surviving is not very good. On the other hand, if you're in a Range Rover with all the modern gadgets, the chances are that you will survive, but there are occasional crashes where if you are in a Range Rover or a tank, you still won't survive. So it was a situation like that. Younger people were getting serious complications and not making it. So the mortality rate was not what we expected it to be. It was much higher. In our experience, when we counted out 3 months, 6 months down the line, we found that the numbers of cases that we were dealing with, particularly acute limb ischemias, were more than double. The revascularization was less than successful. Another important thing I don't think has been highlighted so much in the publications is that some of these patients had COVID 2 weeks before, or even a month before, and they were presenting with thrombotic complications, DVT, PEs, and other complications months later. And then one weapon we had to see whether this was COVID related was COVID antibodies. Early period, sort of the early part of after infection, their antibodies, COVID IgG will be still high. So sometimes if it's 2 weeks after, they may not be positive for the virus, but they still have experienced the virus, and this was a legacy of the COVID. So now I'm going to show you 6 cases which we were challenging and how we dealt with them. The first one was a 70-year-old man. After the first wave, it was in December, he had presented with leg pain, and the GP initially thought it was DVT. Quite often these days, during that time, GPs didn't actually see the patients, but it was on a telephone consultation. The patient complains of leg pain, send them for a DVT scan. So the patient came up to the acute medical unit in the hospital. A DVT scan was negative or inconclusive. So therefore, a proper duplex scan was undertaken. Thankfully, a medical consultant who reviewed the patient identified that the real problem was leg ischemia, and then he was sent to the vascular unit. So that was what we saw on the CT angiogram, the initial CT angiogram. You can see the aorta is thrombosed. There is quite a bit of disease on the SFA being occluded and the distal runoff not being good on the right side. So hence the right leg pain, critical ischemic right leg. So what did we do? We had to think of, certainly this man would not have survived an aorta biofem, standard revascularization. We needed an operation which we would have done quickly, exposing our staff to the minimum risk and getting the best outcome. So what we chose for him was an axillobifemoral bypass. And that was done fairly rapidly, obviously prosthetic bypass. Unfortunately, although initially, first few days, it looked like a successful revascularization, his right leg became ischemic. And this is a thing that you will hear time and time again. After a technically successful bypass, few days later, despite keeping them on anticoagulation, the grafts thrombose. In his case, the right side of the graft went down. And we confirmed that with the CT angiogram. We tried again with the thrombectomy and fasciotomies this time, but unfortunately, he lost his right leg. And subsequent course was that he developed graft infection, and we replaced his graft with a vein graft, and thankfully, he's living, obviously, minus the right leg. Second case was an 84-year-old lady with diabetes, multi-comorbid, COPD, atrial fibrillation, number of falls, was admitted with COVID infection, already sort of supported but not ventilated. So new examination findings of necrosis of toes. This is not an uncommon finding. I mean, even an old person in hospital a few days, even without COVID, you can find this kind of thing. But in this case, this was what we found. So the SFAs were diseased, lower down, and clinically this is what we found, necrosis of the toes. And we decided this patient with 84-year-old with multi-comorbidity, the best course of action was manage it with anticoagulation. And thankfully, again, although she developed further toe necrosis, we had this discussion about should we palliate rather than, that is a discussion that you needed to have every now and then with patients and their families, saying sometimes it's probably kinder to manage the pain and keep them comfortable rather than attempt heroic surgery at that point of time where you might not get a good result. The third case, this was a very challenging case. I was directly involved in this case. A 41-year-old man had contracted COVID. He was a very conscientious guy who was very careful to avoid COVID, but unfortunately, following government guidance to the letter, he contracted COVID, and he was actually connected to the hospital as well. He was a supplier to the hospital and had presented to the A&E department with abdominal pain and leg pain. And I'll show you what his CT scan showed. In the next one, you can see the SMA thrombose. The left leg was iliac to all the way down to the popliteal was thrombosed with very little runoff shown on the CT. So we had to do something for him. This was one of those Range Rovers that had crashed, and he was going to not survive. So we took him to theatre. We did through a femoral exposure, revascularized the left leg, as well as endovascularly recanalized his SMA. I'll show you some pictures afterwards. SMA, and then unfortunately, on the first day itself, he had new calf pain, and we thought maybe we've delayed the revascularization, we should have done a fasciotomy. So we took him back to theatre to do a fasciotomy, and at the same time put a laparoscope in because there was some abdominal distension, and then we identified that there was a segment of small bowel that was dead. So we took, at the same sitting, we did a laparotomy and fairly extensive bowel resection. But thankfully, I can tell you that he's still living, and his stoma has been reversed, and he's doing well. He did not have an amputation. So at the end of the day, this was a good outcome. The lesson was that rather than try and, although he eventually needed a laparotomy, we revascularized his gut fairly rapidly. Rapid revascularization is important, particularly for acute mesenteric ischemias. The fourth case was a fairly obese 69-year-old man who was admitted with left leg pain. So the initial CT scan showed that there was a left popliteal occlusion, and he was transferred to our hospital from a nearby hospital, and that's what we saw, the popliteal occlusion. So he went, first of all, when he arrived, he was in a bad shape because he had COVID, he was delirious, septic, he had infected leg with necrotizing fasciitis, and the only option that we could offer him to save his life was an above-knee amputation. Again, he's COVID IgG positive, and again, he survived and eventually went home, minus the leg, of course. The next one is a good success story. 71-year-old man, in reasonable health. He had mild COVID, but 10 days later, he presented to the hospital with severe right leg pain, and he was quite sick. He had an initial right femoral thromboembolectomy and fasciotomies, but while on ITU, he developed further leg ischemia and had to be taken back to theatre for the other leg. And we revascularized both legs, and eventually, after a stormy period in ITU and outside ITU, he survived, and subsequently, he's come back and seen me and had hernia repairs as well. He's doing well. He's completely independent. He's fully recovered, and the revascularization was successful. The last one that I'm going to share with you is a 32-year-old man. He did have fibromyalgia and recurrent pneumonia, so he's not the healthiest guy, who developed leg pain, and this was in fact due to an extensive DVT, where the leg was kind of being threatened. So you can see on the imaging what he had. He had a iliac vein thrombosis. We put an IVC filter and initiated thrombolysis. He was once again COVID IG positive, and the thrombolysis was reasonably successful, and we did a planned IVC retrieval, but once again, we managed to save his leg. So, the take-home messages are that there was a lot of thrombotic disease, and thrombosis plus distal embolization happened. Some of the pulmonary embolisms that you see were not traditionally pulmonary emboli, but they were kind of in situ thrombosis, with the ground glass kind of appearance that you got with these COVID patients. Some of them were actually, rather than true pulmonary emboli, they were pulmonary thrombi. There are lots of people walking around, 70-year-olds, 80-year-olds with chronic arterial disease. They developed in situ thrombosis. Obviously, distal digital ischemia was exacerbated when they were in a bad way and they needed inotropes. They were in ITU. That sort of showed up the toe ischemias and toe necrosis and so on. So what were our recommendations? First of all, treating a patient with COVID, if they complain of leg pain, if they complain of limb symptoms, don't ignore them. They may well have arterial problem or arterial occlusion, like ischemia. One of the key messages I would say is, if we were to experience a further wave of COVID, do think of COVID IgG, because sometimes the COVID virus itself may have come and gone, and it's only transient that you have shed the virus. So you need to think about COVID IgG if you're thinking about a limb ischemia or a ischemic episode presentation. Unfortunately, despite you're doing your best, the outcomes are not going to be as good as when they didn't have COVID. You do need to think about anticoagulation. Unfortunately, there is no universal agreement about prophylaxis or therapeutic treatments, and you need to use your common sense and provide anticoagulation, antiplatelets as required. I will stop there, and I'll be happy to get any clarifications that you require.
Thank you, Jawaharlal. Being a plenary, I think we generally no questions, but thank you for that interesting talk. We were discussing, we also experienced a fair number of thrombotic events, including myocardial infarctions in some young people. Thank you. On behalf of the college, in appreciation of your contribution, may we present you with this memento.